Good morning, attendees. Happy Friday. Welcome back to the Pacific Dental Conference. We should be very proud to be here in BC. We have over 12,000 attendees, and those numbers are probably going to go higher given that Fridays are usually our #1 day of attendees. So not a good day to be a patient out there needing some dental work today, but very proud to be part of the organizing committee that works year-round to put this wonderful scientific program together. My name is Penny Hatzimanolakis. Yes, wow. You actually need that to get your CE points. Can you remember? You got it? Okay. No. The students call me Professor H. You can do that too. That works as well. So just a few housekeeping rules, just so we can go on with the rest of our session. Rebecca is standing here. She gave us a nice wave. So welcome to those who are out of province, and those of you obviously know that you have a green dot on your badge. You need to sign in and sign out, so scan in and scan out with Rebecca to actually obtain your CE points. So don't forget to do that, especially at the end of the session, because then you won't be able to get, if you walk away, then you won't be able to, because once Rebecca leaves, then so do the CE points. So make sure you have a chance to do that. So the live dentistry stage, its 4th year, although second appearance for our wonderful speaker coming up here. Very excited to have him here again. He really pushes the boundaries of what we can do live. So I'm very excited to see what's going to happen this morning. So let me introduce this wonderful speaker. Ron Zokol graduated from the Faculty of Dentistry at the University of British Columbia. He has mentored study clubs in oral implantology, both surgical and prosthetics. Dr. Zokol received his board certification in oral implantology by the American Board of Oral Implantology in 1996. He is the founder and director of the Pacific Implant Institute in Vancouver. Please help me welcome for his second debut at the live dentistry stage, Dr. Ron Zokol.
Thank you very much. Much appreciated. That fine introduction.
Do you want to speak out to your booth number?
What's our booth number? 330?
Yeah, 330.
Booth number 330, everybody. I'm a terrible promoter of business. It's just outstandingly awful. Anyway, what I wanted to share with you perhaps a little bit about what we're going to do today, and to give you a little bit of background. Penny alluded to the fact that we were giving a program here as a live demonstration last year, and our gentleman, who is I'm going to call him a middle-aged male, pretty healthy, and he presented with an edentulous maxilla, and mandible for that matter, and this is what we started with last year. Our goal for this is a fixed restoration. This is a very, very unique case, and it's very atypical because of the vast volume of bone that is available. Alan has as our patient. I'll call him Alan. He won't get his last name unless he wants you to have it. But this case here, after wearing a denture for some 25, 30 years, he still presents with a maxilla that's bigger than anything you've seen before in your life. And this is very, very unique. And consequently, the surgery is going to be very, very unique. In fact, in planning this out with Nobel, they had never encountered this type of a surgical procedure. And what we're going to do today is related to the fact that the maxilla is so large in terms of its width as well as its height. And I'm going to show you some of that. Just to preface that, what you see on the screen right now shows on the right antrum a mucocele. And last year what we did is that we aspirated the contents of that mucocele, elevated that sinus. This is the mucocele from a three-dimensional radiograph and tomographic images of it. So you can see the extent of it. These things adhere to the lateral and medial walls of the sinus. They're onto the inferior wall as well. They're rather dome-shaped. And they have a very clear yellow, not so clear, but very yellow, what appears to be a dark yellow clear fluid in it. We aspirated that, we elevated the sinus, and you can see probably in the elevation of this sinus generated bone up to about this level right here. And we then did the corresponding sinus, which is a whole bunch easier. It doesn't have a pathology. We did that at a study club. And this is the condition that Alan presents himself with right now. And if you think of where the teeth would be if he was dentate in the maxilla, you can see the degree of soft tissue, the bone structure, the soft tissue structure that presents when he smiles. And this is a pretty much a high smile line for sure. But what we're going to want to do is we're going to want to reduce the height of the gingival tissue, if you will. So what we've got to do is do an osteotomy or an osteoplasty to bring the ridge down. But we're going to do that in conjunction with placing 6 implants in a guided surgery. The lower ridge is pretty common. He presents with a very, very large mandible. Normal configuration, the superior aspect of this, or the crestal aspect of the bone, is very narrow for about 8 millimeters in the anterior region. And that will be plastied down. We don't have time today to do both procedures, but we will be plastiking this down. We'll try and do a demonstration surgery at some time with Nobel and Microdental's help and such to show how the lower arch can be placed guided as well. This is how Alan presents as well when he has his natural denture. However natural a denture can be, but there it is. And the incisal, more importantly, in the design and the philosophy of how you're going to go about the construction. What are the surgeries going to entail that are going to give Alan the result? We have to take a look at the end result. Right now, with his incisal edge position, it's actually very good. I don't want to change the incisal edge position. So if we're going to make teeth bigger, we've got to reduce the alveolar process. So our goal today is to place implants on a guided surgery, then take the guide off, deliver the implants about 5 millimeters into the bone structure, okay, and then plasty the bone down and then suture everything up. So the end result will show a less gummy smile and will allow implant-supported prostheses to be positioned in a fashion against the tissues which should make it look ideal and natural. At least that's the goal. We started with a template. These guided surgeries have to start out with some type of a end-point solution because we don't have, in normal cases, we're deficient in bone structure. And the problem that we have here is that we're not. Therefore, we can't provide a wax setup or a try-in, if you will, of where the teeth are going to be and what they're going to look like. So we're going to work from the original denture with the concept that the incisal edge position is exactly where we want it, and we're going to work from there. So the template was designed with the use of Nobel clinician software and the milling system Mahwah, New Jersey, Nobel Biocare has. We constructed a surgical template. This was designed on the computer. You can see probably the narrowest part of the ridge still allows for a 4 millimeter diameter implant to go in quite nicely. And the posterior areas, well, we're limited a little bit. We still have ample width. If you can take a look at that, that's just a massive width of bone that is not uncommon in the posterior maxilla because of the influence of the antrum. So based on where the teeth are likely going to be, if we can make the presumption the teeth are going to be very close to where they are right now as an end result, at least the occlusal surfaces, the teeth are hopefully will be higher, is our goal. And of course, when we plan it, these are the exit points from the position of the implants. This is the angulation orientation of the implants, and the screw that's going to retain the prostheses will emerge from the prosthetics at this position, which should make it quite straightforward and easy to put together. We have guide pins, so we're going to stabilize the maxillary prosthesis, the guide, if you will, by these 3 guide pins, and we do that. Let's see if I have. No, I don't have that part just yet. But what we have is that we'll orient it in relationship to the mandibular arch prosthesis, and we'll have them close into place and seat that maxillary guide into full position, insert the guide pins, and that will stabilize the upper prosthesis, and then we'll go about actually drilling the osteotomies in a flapless process. And the reason we're going to do it flapless is we've got to remove some gum tissue anyway in terms of reducing the height of the alveolar process. And he has so much attached keratinized tissue that we can lose a whole bunch and still have more than enough tissue to work with. In any case, this guided process uses a different drill sets, and Nobel Biocare has graciously provided that service as well. Orbit Imaging has provided the imaging services to allow us to do this, and that was greatly appreciated. I also want to recognized microdental laboratories, although their services have not been extensive at this process, they're providing all the laboratory services for the reconstruction of the maxilla and mandible at free of charge. And this is much, much appreciated. Kim Connolly, I want to recognize Kim. Where are you, Kim? There she is. Kim here has a service where she actually goes into dental offices, or part of her team will go in and they will draw blood for the purposes of creating platelet-rich plasma, which you can concentrate at 8, 15, 23 times base human value. And that's a nice service. Thank you, Kim, for donating those services. Part of our procedure today is very, very likely going to be including a repair of the right antral wall, because there's a soft tissue defect, a fenestration there that we'll correct. And we're going to do that with the aid of BioLase's WaterLase MD. And so we want to thank BioLase as well for their contribution here. Rocky Mountain Tissue Bank has provided the bone services and all the grafting materials that we've used to help Alan get to another stage have been donated by the Rocky Mountain Tissue Bank, and we appreciate their support as well. Other companies that we're not going to be directly involved with today's surgeries is Hyosin, who's provided help with the sinus grafting protocols, and we very much appreciate that. So with that, I'm going to send this off. We'll get started. I'm going to go scrub. Give me a couple minutes to scrub in, and we'll get this process underway. We're using, actually, Nobel has come out with a new controller for electric handpieces, and is using an iPad 3 onto this controller, and it's a free application that you have to control it. And there's a foot pedal here, and it's incredibly sensitive, so I'm wecking everybody around me as I get this process started. Let's see if we can get the path of draw here. There we go. You got a maxillary tuberosity here. It's pretty thick. So I think what we'll do is we'll take this and